one of the very important disease. Actually, it is a syndrome. It does not just measurement of blood pressure, but usually it occurs along with dyslipidemia, dysglycemia, and endothelial dysfunction. Actually, you find that there is an increased amount of oxygen stress in hypertension. So this hypertension, if it is not corrected properly, leads to heart attack, coronary artery disease, chronic kidney disease, stroke, and various other complications, including peripheral vascular disease. The magnitude of the problem is enormous. That you find that even in India, in the urban cities like Chennai, Mumbai, and Delhi, you find about 30 to 40% of the people are suffering from hypertension. Below the age of 50, the females may have a lower incidence, but after the age of 50, they are equal with the males. After the age of 50, the incidence appears to be 50%. After the age of 65, the incidence appears to be 60%. You can understand that whenever you see a patient, for whatever complaint they come, you must always record the blood pressure. That's the best way. JNC7 has defined the hypertension as not above 140 by 90, but actually above 130 by 80. They call it as a pre-hypertension. Anything above 130 by 80 millimeters of mercury in people above the age of 18 years is a pre-hypertension. Pre-hypertension has got the same risk as hypertension, as I already enumerated earlier. It's almost like impaired glucose tolerance. Impaired glucose tolerance has got the same complication as diabetes mellitus established. Therefore, it is very important that we should try to keep the blood pressure below 130 by 80, particularly if the patient has got albuminuria or even a microproteinuria, or if the GFR is less than 60 milliliters per minute. It is important that you should keep it lower down. And if it is going to be above 1 gram protein excretion, you must keep it below 125 by 75. That is the way in which that the organ dysfunction will be prevented. Either a cardiac dysfunction or a kidney dysfunction or cerebrovascular disease. Well, after mentioning about the magnitude of the problem, the amount of money that is spent both by the country as well as the family is enormous, and so you should always try to prevent hypertension. Particularly, it is very important that you should understand the pathophysiology of hypertension. You find that the oxygen stress is the most important thing. That if you consume more of fried food or a salty food, you find there is an increased oxygen stress. The oxygen stress gives rise to endothelial dysfunction. Endothelium is the largest organ in the body. Wherever the blood vessel goes, the inner aspect of the blood vessel is the endothelium. So if there is an endothelial dysfunction, there is increased endothelium 1. And the increased endothelium 1 gives rise to increased amount of renin-angiotensin. Previously we used to think that in the kidney the juxtaglomeralar apparatus is the only one that will create renin and angiotensin, etc. But then we know then even the vascular tissue in the brain, the heart, and the peripheral vessel has got the angiotensin to producing capacity, and so there is a diffuse renin-angiotensin aldosterone axis in even the so-called primary hypertension. Here, the kidney plays a very pivotal role in the pathophysiology. One, that genetically there are some people who are not able to excrete as much salt as other person who can excrete salt. So the salt and water retention leads to the blood pressure, and the increase in the endothelial dysfunction produces renal arterial constriction, and that constriction will lead to increased amount of sodium and water retention, and which will perpetuate the hypertension. The endothelial dysfunction is not only affect the vascular tree to produce vasoconstriction, but there are a lot of the angiotensin receptors, even in the podocyte of the glomeruli and in the tubules and in the mesangial cells. You find that there is increased production of the angiotensin 2 even in the kidney if there is a severe endothelial dysfunction. I think this much is sufficient, even though there are many other hypotheses which can contribute. What I wanted to stress is that it is not only the kidney disease which produces hypertension. Even in the so-called primary hypertension, kidney plays a pivotal role in the causation of hypertension. At the same time, you have to understand if you don't control the hypertension, the kidney gets destroyed, and it is the brunt of the attack is on the kidney, and then you can get in a malignant hypertension an acute kidney failure or even a chronic kidney disease because there is a vessel going to spasm in the kidney. Well, another important thing that you should know is that there is always the hypertension is always associated with diabetes mellitus. Diabetes mellitus and hypertension are like cousins, and most of the cases of diabetes, there is 50% incidence of hypertension along with diabetes in the so-called type 2 diabetes. The same way, in hypertension there will be 30 to 40% of them will have dysglycemia or hyperglycemia, and it is very important that we should look for both whenever we investigate the case. One of the important things in the diagnosis is that you go through the history of the patient, particularly when there is a family history of hypertension. There is a tendency for the offspring to develop hypertension. When there is a family history of obesity, then there is a tendency for the patient to become obese, and that's the most important history. More than that, how much salt that he consumes. Those who take oily food and food with a lot of chili, hot stuff, they will consume more amount of salt, and excess salt definitely leads to high blood pressure. Then one of the important things that one has to understand is consumption of alcohol. If you take the incidence of hypertension in the general population, it will be 30%. But if you take the alcoholic population, you will find it is 50% of the people who are hypertensive. In the same way, the smoking is another important factor which leads to hypertension. The people who smoke have higher incidence of hypertension, higher incidence of heart attack, higher incidence of lung disease like malignancy, carcinoma of the lung, higher incidence of acid peptic disease. So, hypertension is one of the important factors. Even it produces a renal atherosclerosis and produces a renal vascular hypertension, smoking. So these are the important history that you should ask when you investigate a patient with hypertension. When you examine the patient, you will find whether he is obese or not. Once the BMI is more than 30, his tendency to have high blood pressure is very, very high. The next thing is that you should look for the palpation of the vessels, and you may find that there may be some reduction in the pulse volume in the lower limb. It is a peculiar disease known as aorta arteritis which can give rise to hypertension. Another important thing is, has he got any puffiness of the face? Has he got any pedal edema? Particularly early morning puffiness of the face indicates that there is a renal hypertension. It may be an acute nephritis or it may be even a chronic kidney disease. If he is pallor, anemic and hypertensive, invariably it is going to be a chronic kidney disease which is responsible for hypertension. If you got, suppose an young lady who has got a butterfly-like patch, maculopapular rash in the face, it is suggestive of a systemic lupus erythematosus producing high blood pressure. Or if there is a young man with a vasculitic patch in the leg, or any part of the body, or erythema nodosum or erythema marginatum. Once again, it indicates an autoimmune disease like polyarthritis nodosa. So, though it may not be so common, but it is important that you should rule out secondary causes of hypertension before you label it as a case of primary hypertension. Of course, primary hypertension is 90% of the incidence, whereas 10% only is secondary hypertension. The largest in the secondary hypertension is renal hypertension, renovascular hypertension. Then comes the endocrine hypertension like pheochromocytoma, adrenal adenoma. So, we have to rule out while investigating the case also. The urine analysis is a very important thing. Actually, it's like a renal biopsy. If you look at the urine deposits and you find a lot of RBCs, it means there's glomerulitis. So, and if you find there is protein in the urine, once again it indicates that there is a glomerular involvement. It is probably renal hypertension. Well, severe hypertension, even without renal disease, can cause the renal damage and produce proteinuria. But that's not very common unless you are seeing a malignant hypertension, where the diastolic pressure is more than 120 and the systolic pressure is more than 180. It's a very severe hypertension. And if you look at the fundus, you will find that there may be changes of hypertensive retinopathy in the form of narrowing of the blood vessel. You may find even papilledema, and you may have superficial hemorrhages or even deep hemorrhages, in the punctate hemorrhages. So it's important that in every hypertension you look at the fundus. It will also show that whether it is a small vascular disease is there, because hypertension can produce a small vascular disease like nephropathy and retinopathy, and also it can produce a large vascular disease like stroke or myocardial infarction. The next investigation I would say is a total count, differential count in ESR. You will find if these are grossly elevated and there is eosinophil increase, I think you may think of an autoimmune disease. Eosinophilia, raised ESR, and RBCs in the urine, and an young lady with cutaneous manifestation which I mentioned suggests a systemic lupus erythematosus. Well, you've got to do the investigation to point out the etiology and also the investigation to point out the complication. For example, X-ray test will show whether there is a left ventricular hypertrophy or a cardiac dilatation, indicating that the hypertension has been there for quite some time. And the ECG also can show some changes of left ventricular hypertrophy or C-wave changes or ST segment changes, once again indicating cardiac involvement. If you do urea, creatinine and creatinine clearance, more than the creatinine clearance is very, very important. Particularly in an elderly individual or thin individual, you do a serum creatinine, it may not show the real renal status, but actually if you do a creatinine clearance, and even if you can't collect a 24-hour urine, you can do a eGFR, estimated GFR, that can indicate you whether you've got a creatinine clearance less than 60 milliliters per minute. You can actually grade how much of CKD is there. 120 to 90 will be the grade 1 CKD, 90 to 60 will be grade 2, 50 to 30 will be grade 3, 30 to 15 milliliters will be grade 4. The creatinine clearance is less than 15 milliliters. You call it as grade 5 CKD or end-stage renal disease. So it's important that you should not only estimate whether the kidney is involved, but the degree of kidney involvement is also very important. At the same time, suppose there is a history of weakness on half of the body, or what is known as a drop seizure, then it is important to investigate the central nervous system. If there is a story of difficulty in using one half of the body, even transiently, or a drop fissure. Drop fissure indicates that the posterior part of the vertebrocerebral artery is involved, and one half of the body is anterior part is middle cerebral artery involved. So you may have to do a CT scan or a MRI angiography depending on the renal status. Well, of course, if you think that the urine, the blood pressure is very high, it has become very soon. Actually, you are a person who is looking after the patient, and you find that the BP has gone up very quickly to 190 by 120 or so. Then also you find that there is a bruit in the paraumbilical region, and you find that the fundus examination showing severe changes of retinopathy. I think you should rule out a renovascular hypertension. So in that particular case, it's not only important to do the ultrasonogram. Ultrasonogram will show you the size of the kidney, that maybe that one kidney is smaller than the other kidney, particularly if the left kidney is smaller than the right kidney. It's quite significant, because usually the left kidney is 1 centimeter bigger than the right kidney, and so it is very important to do a rapid sequence intravenosulogram. You can do a digital subtraction angiography if you want to do a non-invasive investigation, or if you suspect very seriously that an angiography itself will confirm that there is a renal artery stenosis or not. And if you think that the blood pressure is fluctuating, sometimes it goes to 220 by 130, suddenly it comes to 120 by 80, and there is a flushing of the face, and there is telltale evidence of capillary spots or neurofibromata. It suggests that it is a case of pheochromocytoma. So you've got to do a 24-hour urine estimation for catecholamines and the VMA. I think that's an important thing. And when you do these things, you've got to do sodium, potassium, bicarbonate and chloride. When you do sodium, potassium and bicarbonate, chloride, and we are not using any diuretic, and you find that there is a persistent hypokalemia, that's an indication that this patient may be suffering from adrenal cortical adenoma. There are some people who have investigated, particularly for adrenal cortical adenoma, they find 20 to 30% of them are suffering from adrenal cortical adenoma, because a very high incidence. In my own four decades of experience, I had only about 2 cases of adrenal cortical adenoma which have been operated, and there was a semi-cure of hypertension. Why I am mentioning this? These are all curable hypertension. Renal artery stenosis, if you reconstruct the stenosis by either angioplasty or by surgery, the hypertension can be cured. Even if it is not cured, at least the number of drugs can be reduced to a considerable extent. The same way, the pheochromocytoma is removed, the hypertension is cured. The same adrenal cortical adenoma is removed, again the hypertension is cured. Whereas in cases of primary hypertension, that you have to give the therapy for quite a long time. Yet another important thing which I already mentioned, that there is an association of diabetes along with hypertension. As type 2 diabetes is associated with hypertension, diabetes also can have diabetes. So you must do a fasting, even if you don't do a GTT, to do a fasting and a postprandial blood sugar. The fasting blood sugar is more than 100 milligrams, indicates that it's got impaired fasting glucose. If the postprandial blood sugar, after the lunch 2 hours later, if you do the blood sugar and if it is more than 140 and it is less than 199, it is an impaired glucose tolerance. If it is 200, even at the random or a postprandial, you can immediately dump him as the case of diabetes. So that's very important to, and I already said in my introduction that it is a syndrome associated with dyslipidemia and dysglycemia. So you must do a lipid profile routinely in every case of hypertension, and so particularly if the LDL and triglyceride is increased and HDL is decreased, it's very important that you've got to not only treat the hypertension but also treat the dyslipidemia. and particularly in Indians have a high incidence of coronary artery disease. Indians, Pakistanis, and Bangladesh, because their HDL cholesterol is low and the triglyceride is very high. So it's very important in hypertensive you should do a lipid profile. Well then, these are the very important investigations, and let us look at how exactly that we can go about to treat this patient with hypertension. Well, very important thing is that the lifestyle management is the most important thing. That's a non-pharmacological method of treatment. Number one is exercise. Exercise to see that the blood pressure is, the weight is kept in normal. It is less than 25 BMI. It is less than 25 BMI, and if the BMI is higher, then we must always ask the patient to reduce the weight. So it's not only about 45 minutes of walk, but maybe that you have to increase it to 90 minutes per day. And you should see that smoking is completely stopped. That's the taboo for alcohol. And then you should try to use more of three courses of vegetables, 3 courses of fruits. What is known as a diet against systemic hypertension? That diet is one of the things that has been done in the United States and found 3 courses of vegetables and 3 courses of fruits and a less amount of salt and less amount of saturated food, dairy food, that is low fat milk and low fat curd, are the one which will be able to help. And if it is a non-vegetarian, it is fish and chicken which will be better to replace it meat, pork and beef. So beef, pork and meat should be a taboo. I think that's one of the ways in which that even if he is an hypertensive, I don't think we should try to discourage him to playing tennis or shuttlecock or walking for about 45 to 50 minutes, because you should tell them that the more they walk, that there is a more amount of peripheral vasodilation and the less number of antihypertensive drugs that they will be able to take. So these are the lifestyle management. And the one of the important thing in the food is that not only you reduce the salt, actually human beings need only about 2 grams of salt, but we take about 12 grams of salt, and so you cut it off to 4 to 5 grams of salt every day. And if it's a severe hypertension, then salt should be a taboo. And slowly, after the hypertension is controlled, you can give him 1 to 2 grams of salt. There are some other minerals like potassium. High potassium food is against hypertension, like coconut water, orange juice, sweet lime juice. These are all good actually for reducing the blood pressure. Maybe that alone may not be useful, but it's a good thing to keep the blood pressure normal. Also increase amount of magnesium and calcium. Calcium comes from milk and curd, and the magnesium comes from the green vegetables. Green vegetables and the red vegetables, things like tomato, these are supposed to have antioxidant properties. I think that's about non-pharmacological management of hypertension. I think the next thing is we'll go to what will be the drug therapy to hypertension. Actually, the JNC7 has categorized the blood pressure into 130 by 80 to 140 to 90 is a pre-hypertension. In this particular stage, we can have lifestyle management itself that may reduce the blood pressure. Whereas if it is more than 140 by 90, besides lifestyle management, we can use drugs like ACA or ARB. I told you that at the beginning itself that the primary hypertension itself, there is an increased renin-angiotensin aldosterone axis because of the existing endothelial dysfunction. So ACE-ARB will be an ideal drug. Why I say that? Because you find that amitriptyline is not only reduces the blood pressure, it also is anti-inflammatory and anti-cytokine, and it is vasodilatory. It reduces the preload and afterload to the heart, and so in today's treatment of blood pressure is not only just reducing the blood pressure, but also beyond the reduction of the blood pressure, giving us organ protection. So ACE and ARB can give rise to protection of heart, protection of kidney, protection of vascular system and so forth. So that's why I am talking about ACE and ARB. Well, there are some 20% of the people who may have incidents of cough, and they cannot be tolerate the whole thing. So ARB will be a good choice for them. I think irbesartan, telmisartan, or two common sartans which have scored over in the landmark trials. Like, for example, the IDNC trial has shown that the irbesartan is a good drug for diabetic hypertension. And many other trials have shown that telmisartan is a very good drug. And now we got olmesartan also. So these drugs can not only reduce the blood pressure, but have all the advantages which I mentioned to ACE. In addition, it doesn't produce cough. Another advantage of the sartans are it blocks the angiotensin II receptor, whereas the ACI blocks only the ACE-induced and the angiotensin II. So that's only about 60% of angiotensin II. The 40% is not blocked, and so ARB will be quite good to block majority of the hypertension. Yet another drug which has come into the market is direct renin inhibitors, like allosterine, which will block the renin itself because it blocks the renin receptor, and so you will not be able to form the angiotensin I because the renin has to combine with the angiotensinogen to form angiotensin I. So DRI, direct renin inhibitor, is a product which has come out 20 years after the investigation, and it has got a very long half-life, 24 hours, and so 300 milligrams given is a better dosage schedule to reduce to moderate hypertension. But DRI combined with the angiotensin receptor blocker will be much better choice in preventing organ dysfunction when compared to DRI alone. Usually, if you look at the people of hypertensive who are taking medicine, they take more than 2 to 3 drugs. So the ACE and the ARB alone may not be sufficient. So you've got to use calcium channel blockers. The best among the calcium channel blockers are the long-acting calcium channel blockers, like amlodipine, lepcanidipine. Better still would be cilnidipine. Amlodipine has the disadvantage of producing an edema in about 20 to 30% of cases, which alarms the patient because of the increased venodilatation besides the arterial dilatation. But cilnidipine will not produce this, and cilnidipine produces a block of L and N. L and N block leads to reduction in the epinephrine and norepinephrine, and there is a vasodilatation. There is no reflex tachycardia, and then it almost behaves like a ACE and ARB. And so the 4th generation calcium channel blocker will be a preferable one in case of when compared to amlodipine or lepcanidipine. And then they can also use drugs like verapamil, particularly extended release verapamil, 120 to 200 milligrams is a good dose for hypertension. Usually it is ACI, long-acting calcium channel blocker like cilnidipine or amlodipine. Then you have Beta blocker. Beta blocker is clearly good in that the evolution of beta blocker from atenolol to bisoprolol and extended it to metoprolol and carvedilol has proved that they give a cardio protection in addition to reducing the blood pressure. So the 3 trials which are on diastolic heart failure have proved bisoprolol, extended metoprolol and carvedilol are extremely good. Particularly carvedilol is quite a good drug in the sense that it is an antioxidant, it reduces the proteinuria, it is also anti-inflammatory, and it's alpha and beta blocker. So it produces vasodilatation, and the reduction in the cardiac output is not that much as in cases of bisoprolol. Today what you have to understand is atenolol is no more in the vogue because atenolol only reduces the blood pressure and it only works for about 16 hours, not a 24-hour drug. And so I think you should stop prescribing atenolol and switch on to bisoprolol or extended release metoprolol or carvedilol. Then there is another entity known as the diuretic. I think diuretics must be, you can start, today's drug therapy in hypertension is individualized. I would like to use diuretics in cases of a volume overload. The hydrochlorothiazide or chlorthalidone, better still. Chlorthalidone is a long-acting diuretic which can be used in mild hypertension. Chlorthalidone can be used also in a case of isolated systolic hypertension. Whenever you find the hypertension blood pressure, systolic pressure is more than 160 and the diastolic pressure is always less than 90, you call it as isolated systolic hypertension. This isolated systolic hypertension is present in elderly people and also in diabetics. Actually, the systolic hypertension has got more morbidity and mortality when compared to diastolic hypertension. And so it's very important that calcium channel blockers and the diuretics like chlorthalidone are the drugs which can be used for isolated systolic hypertension. They are the specific drugs. The same way as we said, if there is a coronary artery disease and hypertension, I would like to use the beta blockers with combined with ACA or ARB. And if there is a chronic kidney disease, the best drug will be the ACA and ARB. And if the blood pressure is not controlled by these 2 drugs, you can combine with carvedilol or bisoprolol. Particularly if there is a proteinuria, I think the ideal drug would be ACA, ARB and carvedilol. I think even telnidipine is supposed to reduce the proteinuria. And if you are using 3 drugs, as I said already, that many of the cases of hypertensive they use 3 to 4 drugs. Instead of giving the maximum of one particular drug, you try to give 10 milligrams of ramipril and 5 milligram of bisoprolol and 10 milligram of telnidipine. So you will find that they have different mode of action, and so the patient will be more beneficial when compared to the giving maximum dose of one particular drug. Another important thing that you have to understand is the so-called resistant hypertension. When you use 3 drugs and also a diuretic or even without a diuretic, you find the BP is not brought down below 140/90. It is defined as a resistant hypertension. Well, in this particular case, I think we have to use not only ACA, ARB, but also beta blockers, and sometimes we've got to use the combination of clonidine. So clonidine can be given 200 microgram to 900 microgram. Actually, you can give 300 microgram 3 times a day. That's the maximum dose that you can give. It is centrally acting adrenergic drug, and it will reduce the blood pressure. Only thing is, sometimes when they feel drowsy, and if you continue the whole drug, then you will find that the blood pressure will come down and the side effects also will disappear. And in spite of giving clonidine and ACA, ARB and cilnidipine, you find the blood pressure is high. They give aldosterone antagonists. Aldosterone or better still eplerenone. Eplerenone is the evolution of aldosterone because the aldosterone addition has definitely reduced the blood pressure much more than the three drugs that we are giving. So, in resistant hypertension, the usage of aldosterone or eplerenone is very, very important. Then there are some, but only thing is when you use ACA, ARB and aldosterone, the incidence of hyperkalemia is very high, and so whenever you do the repeat urea and creatine once a month, you should also do sodium and potassium, and the potassium level should be kept below 5 milliequivalent. Then you can also use minoxidil. Minoxidil is available in India, and 5 to 10 milligram immediately brings down most of the case of resistance. I have no resistant hypertension at all because I use either clonidine or you can also use a combination of the three drugs which I already mentioned, and prazosin. Prazosin can be given up to 20 milligrams. To begin with, you can give 5 milligrams twice a day. Particularly when the patient has got hypertension and enlarged prostate, prazosin will be the ideal drug of choice. And in resistant hypertension also you can use prazosin, particularly the extended release prazosin, which will cover for about 12 hours or so. That's very important. I think I have covered most of the important drugs which have been. There are many drugs which are coming up, and I don't want to talk about it to a person who is in the front stage to treat the hypertension, particularly the consultants of general medicine. So I would like to end up here saying that it is not only important to use the lifestyle management and the drugs, but also it is important associated abnormalities like dyslipidemia. The cholesterol has to be reduced below 180, and LDL cholesterol should be reduced below 100 milligrams. The best drug and the triglycerides should be reduced below 150. The best drug to reduce cholesterol and LDL cholesterol is atorvastatin or simvastatin. Atorvastatin given 40 to 80 milligrams will be the ideal, and you've got to, in spite of the fact you bring down the LDL cholesterol, you have to continue the atorvastatin at a lower dose for a long time, because the statins are proved they not only reduce the LDL cholesterol and increase the HDL cholesterol, but it also is anti-inflammatory and anti-cytokine and reduces proteinuria. Also reduces the blood pressure by producing vasodilatation. And so it will potentiate the action of ACE and ARB and the other antihypertensives. So it should be there. And quite often in the obese people with hypertension, you find there is increased uric acid. Also in cases of chronic kidney disease, particularly with IgA nephropathy and various other glomerulonephritis, uric acid will be high. Hyperuricemia is very bad thing, because hyperuricemia can lead to accelerated atherosclerosis. Actually, there is an hypothesis in the United States where the uric acid itself is responsible for obesity. Well, actually, they use a cheap sugar made out of fructose. The fructose-made sugar increases the uric acid. Uric acid, in turn, increases the obesity. So, in addition to the enormous use of pork and beef, and also fast food and high salty food, uric acid is also responsible for increased obesity. So, you must bring, uric acid produces endothelial dysfunction. That is why it accelerates atherosclerosis. And therefore, it increases the CRP, C-reactive protein. So, you must use drugs, febuxostat or xyluric, you can use for reducing the uric acid. Particularly, if there is a raised urea creatinine, febuxostat will be the ideal drug to reduce uric acid levels. I think I have comprehensively conveyed everything, except that I left one particular thing. It is not only obesity that is important to reduce the blood pressure, but it's also important that portal obesity has to be looked after. The waist circumference should be less than 90 centimeters in male and less than 80 centimeters in female. And if it is more, it contains a large type of fat, white fat, which is supposed to be atherogenic fat. So it produces, it's almost like an endocrine hormone. It produces a lot of cytokines. And there is increased leptin, and that leptin also can give rise to problems. And therefore, that is very, very important that the blood pressure has to be looked after. And according to the JNC classification, that you've got to reduce the blood pressure even in normal individuals below 130/80, so that they don't have a pre-high stitch above 130/80. Thank you very much.